going back to the pelvic exam and the rise of gynecology, so often what you see in this history is that these innovations do eventually lead to better outcomes for patients. And we're all
Right.
now so pleased, that we have modern gynecology and obstetrics, but that initial period normally is pretty bad news, or at least bad news for some. Well, I mean, I'm sure we'll get on to the development of gynecology and the use of slave women's bodies
Yeah.
as, yeah, right. But also for, say, yes, the women giving birth in hospitals at a period where actually it is more dangerous to give birth in a hospital because of the disease transmission. Like, it's a rocky road getting to these good outcomes often, and it can
Yeah,
take a really long time.
absolutely. And I think that part of it is, I mean, it's about nuance, right? It's about not making assumptions that technology is always the solution, or
Mm.
an over reliance on technology. This assumption that EFM, electronic fetal monitoring, is always going to be the best path to preventing any kind of dangers in childbirth, when in fact there's been studies that shown that that's a problematic conclusion to make, that there isn't necessary correlation between one or the other. Or, I mean, another way to think about it when I talk to obstetricians is that medical training along the way, there's been something lost as well as something gained. That you may gain the technology, but then the training, an obstetrician isn't necessarily trained to use their hands as much, to palpate, to understand by feel, and to rely on technology to provide the answers for them. Because sometimes technology screws up, right?
Mm.
And then what do you do?
Mm.
So I think this kind of, I mean, this is a broader, I teach history of medicine and public health. And one of the first things I try to convey to my students is that we're into a culture that kind of celebrates innovation and technology and discovery as all leading to progress. And we're less focused on what is potentially lost along the way. Or just questioning the technology. Are we sure that all the answers lie there?
Yeah, and there's always a strong urge within medical science to be overconfident on the latest thing. And there are so many examples of this. Like in the mid-20th century, the push to get all women to use formula and to give up
Right.
breastfeeding, which was then reversed. You see this happen continually. So there does seem to be a sort of, I guess, a kind of personality maybe that's drawn towards this kind of style of innovation, which is both, good in the sense that obviously you do sometimes create these fairly miraculous technologies. And the thing is that childbirth is painful and dangerous. It just is. It always has been. And to some extent, what we're trying to do in lowering maternal mortality is keep mortality levels artificially low. Right. So you do need a level of kind of artificial intervention in order to make that happen. But there's clearly a scientism drive often within the discipline, and an overconfidence within the discipline that causes tragedy often.
Right. Absolutely. And if you just look at maternal and infant mortality rates in various countries, there isn't a clear correlation between the amount of money spent, for example, and good outcomes, right? And the US is a great example of that. It's the most expensive place in the world to give birth, but look at the outcomes. They're not nearly as good, for example, as in the UK. And the UK uses many more midwives than obstetricians, right? So there's this I would say, an over-reliance on obstetrics for what we call normal birth, right? Obstetricians are great and necessary, especially when there's high risk situations, but they don't receive the same type of training that a midwife does for, again, normal birth.
Although, of course, the conflict that we've had in the UK system of late has been around actually midwives trying to discourage the use of caesarean section, trying to exclude obstetricians from the process. There's this still quite serious conflict between the two professions, and
Sure.
lots, which goes back, as we know, centuries. I know that in the NHS system, it is actually cheaper to deliver through caesarean, even though caesarean is, for the system, even though caesarean is more expensive upfront, because you're so much less likely to cause long-term brain injury to the baby, which is enormously expensive to the state in terms of
Interesting. Okay.
long-term support that then has to be paid out. So, it's difficult, isn't it? And this is the thing, maternal mortality, I think people have a bit of a tendency in looking at this history to probably overestimate maternal mortality and maybe underestimate child mortality. I forget the numbers now, but my memory is that actually, in the sort of pre-modern environment, your chance of dying sort of per pregnancy is not that high, actually. I mean, you'll know, every woman will know a woman who has died in pregnancy or soon afterwards, but it's not as dangerous as just childhood, which was spectacularly dangerous for a long time. Do we have any idea like what proportion of women would, if we didn't have modern obstetrics, what proportion of women would die in childbirth?
I mean, it would certainly be high, and I'm in no way suggesting we should do away with obstetrics. It's just pointing out that it's a field that is very research-based and reliant on technology in a way that doesn't always make it a better outcome, I guess is all I'm trying to say. And that, and part of what was lost along the way is, for some women anyway, the meaning, the experience for the laboring woman, right, who may become scared or fearful or avoid a hospital because it feels over medicalized, and that in turn could lead to bad results. So it's sort of understanding it as both a medical event and something that has meaning for the family more generally.
Yeah, and that isn't strictly an illness in the way that most other things that we'll see you put in front of a doctor are.
Right.
Yeah.